Excellent. Well, thank you both to Tracy, Nader, and the Planning Committee for the opportunity to talk to you this evening. And so I'm going to bring some energy just in case you all stretched out that happy half hour into a whole hour and a half and try and keep this fun and engaging. So I'm going to be talking about the acute management and surgical indications in the setting of uncomplicated diverticulitis. I have no disclosures. I'm going to kind of try and answer three questions in my 8 minutes. I'm going to start with the difference really quickly between uncomplicated and complicated diverticulitis, such that we're all on the same stage with some definitions, and also talk about, answer three questions. So for uncomplicated diverticulitis, who needs the operating room? Who can we treat without antibiotics? And what about recurrent disease? All right, so for the first one, I'm going to start with complicated diverticulitis. So complicated diverticular disease is defined as diverticulitis with an abscess, phlegmon, free perforation, fistula, obstruction, bleeding. Basically, you think of everything except your run-of-the-mill, very basic diverticulitis. In these images, you can see here free fluid around the gallbladder, phlegmon abscess here in the pelvis, and extensive free air in that the one in the bottom left. So if that's complicated diverticulitis, uncomplicated diverticulitis is diverticular disease with localized diverticular inflammation and none of the other things I talked about before. And so that's what we're going to be talking about today, uncomplicated diverticular disease. So who do you need to admit? And this is just a kind of a basic run through. We talk about complicated disease before, but folks with sepsis, microperforations, immunosuppression, high fever, leukocytosis, severe abdominal pain or diffuse peritonitis, people of advanced age, people with significant comorbidities, if they're intolerant of oral intake, lack of social systems or failed outpatient treatment, these are all the folks that you want to go ahead and admit to the hospital for management. And what should that management be? Generally, the four pillars are antibiotics, IV fluids, pain control, and bowel rest and a clear liquid diet. All right, so of this group, though, who needs the operating room? And I would make the argument that it should be really driven by physiology. So first, ask yourself, is there an abscess to drain? Is there some other non-surgical method that you can use to gain source control? And Richard's going to talk next about an abscess, so I'll steer clear of that. The second question is, can they tolerate observation? And so an example of some folks that might not be able to tolerate observation are folks with significant COPD, heart disease, significant frailty. These are the folks that you probably want to gain source control on sooner rather than later. The other group of people that we operate on for uncomplicated diverticulitis are simply those that we can't get out of the hospital any other way. Despite maximal medical therapy, they remain intolerant of POs with significant pain. And there's the folks that you're going to need to operate on just so that they can leave the hospital. And I would argue that again, the four real big things you need to think about are physiological things: tachycardia, hypotension, patient factors, again, such as COPD, heart disease, and then really if they fail to improve. Again, physiology and inflammation is a fickle thing. Some folks tolerate stool in the belly without much in the way of sepsis, while other people have just a little bit of inflammation and it sends them into a real storm. So again, I would argue that for uncomplicated diverticulitis, your decision to go to the operating room should be driven by the physiology of the patient. So the next question I wanted to try and answer is, who does not need antibiotics? And the three trials that we have to guide us are actually from Nader's side of the Atlantic. They were the AVOD trial in 2012, the Dutch diverticular disease study in 2017, and most recently published from Spain, the Dynamo study. And each of these have a little bit of different flavors, and I think my slides will be available for you all to really dissect, so I won't go into them. But I will say that the end result of all three of these trials, the first two dealt mainly with inpatient management and the Dynamo study with outpatient management, was that it looks like for uncomplicated acute diverticulitis, you do not need antibiotics to treat this disease process. This kind of goes against current dogma in the United States, and I think that time will tell to see whether we start to adopt these practices. But if patients are uncomplicated, and again, especially if they can leave the emergency department, there is good data out there to suggest that they do not need antibiotics. All right, so what about recurrence? I'm going to talk a little bit because this is a field that my group and I study. So when you look through the American Society of Colon and Rectal Surgeons and you look at the guidelines that they put out, back in 1995, they recommended that elective resection should be considered after 2 well-documented attacks of diverticulitis depending on age. This is great because as surgeons, we count, and we can count really well. 1, 2, okay, your colon needs to come out. It gets a little bit more difficult, a little more nuanced here because after 2 attacks of uncomplicated diverticulitis, resection is commonly recommended, but resection may be recommended for patients with complicated diverticulitis after a single attack. In 2006, and go kind of almost 180 degrees. The number of attacks of uncomplicated diverticulitis is not necessarily an overriding factor in defining the appropriateness of surgery. Because of their longer lifespan, younger patients will have a higher cumulative risk for recurrent diverticulitis. And then in 2014, and then in actually one of our speakers today, Dr. Hall's paper, the decision to recommend elective sigmoid colectomy after recovery from uncomplicated acute diverticulitis should be individualized, which then begs the question, okay, how do we individualize that decision? We really have 2 randomized controlled trials right now to guide us, with a 3rd currently under enrollment in the United States. The first is the DIRECT trial, which enrolled patients with recurrent, which they called 3 or more presentations with clinical signs of acute diverticulitis within 2 years or persistent abdominal complaints to either surgery or observation with crossover as necessary. They enrolled 109 patients. They found that the surgical group at a number of different times, 3 and 6 months, had improved patient-reported outcomes compared to the observation group. But also really worth noting there in the right lower quadrant is that 46% of patients in the conservative group ultimately required surgery due to severe ongoing abdominal complaints. And these patients looked to have higher acute or greater disease burden at the time of surgery, at the time of enrollment, excuse me. Then there was a laser trial which randomized 90 patients to laparoscopic sigmoid resection. Their primary outcome was the Giglia patient-reported outcome measure. They observed 10% risk of major complications with surgery, and they saw an improvement in scores in the surgery group. So the takeaway that I would give you from these 2 randomized controlled trials are that surgery can improve outcomes, but we still don't have a great sense of who will benefit from an operation. This is, again, something that my group and I are studying, and we recently performed a qualitative study where we interviewed 25 surgeons, and we asked them about decision-making for diverticulitis. 5 main themes came up: patient factors, surgeon factors, benefit outcomes, risk of surgery, risk of observation, and then also a discussion upon how they decided. And this provides a little bit of a conceptual framework about how surgeons, at least in North America, are conceptualizing this decision. So I'm going to give you 3 points in conclusion. Outside of frank perforation, the decision to operate should be based on physiology for uncomplicated diverticulitis. Antibiotics may not be necessary for outpatient uncomplicated diverticulitis. And in cases of recurrence, we operate for quality of life. Thank you all so much for the opportunity to talk.